without further ado, we'll move on to our first speaker for the night. So handing over to Annika to take us through her questions. Thank you, Annika.
All right, so I hope everyone can see the slides now. Perfect. Okay, thanks. So this slide is just sort of lists out what the curriculum describes under neurology and ophthalmology. And it was just as a reminder to say that the exam isn't testing us on every tiny detail of all of these conditions. It's a test of our knowledge of the guidelines and recommended best practice for these conditions. So just using that to help guide your revision for the purpose of the exam. And just like the previous formats, we'll go through a series. I've got 7 questions, and so hopefully we'll go through some of the common themes in the exam, and maybe we'll use a minute or a minute and a half for the questions and the answers, and then we'll have a bit more time left over. So I'll let you go through question 1. Okay, and we'll give you some time to answer it, and we'll just put the question in the chat as well in case you need to look back at it. So it's, what's the next most appropriate treatment? Okay, so we'll just give about 10 or 15 more seconds. Okay, so quite a mix. So so the diagnosis that they were leading to, obviously, I think everyone would have got to, was bacterial meningitis. And the guidelines around this are from the BIA and the NICE guidelines to look at. The BIA guidelines are quite good just from the exam perspective. And I'll just go to the slide that I think if you are going through one bit of one of the guidelines on bacterial meningitis before the exam is this column. So when the exam, when we're writing the exam, the questions, they don't really have a lot of words to play with. So they will just put specific things in to help allude to what the answer they want. And so, for example, in this lady, they mentioned that she was 60 years old, and that's where adding in amox or ampicillin, in this case, to your kef and your dexamethasone came in. They could have very easily changed the question to travel history or, penicillin allergy. So I think it's just worth knowing what your standard treatment is and then adding it. So it was, and I think if you had this, then you would have got to the answer. Were there any questions, Nick, in the chat? This is a bit of a straightforward one. Okay, that's no. Okay, so question 2. I'll start my timer. Okay, so this is asking us about a young man with an acute neurological syndrome and neck pain, and they've given us one positive neurological finding. And the question is, what's the best diagnostic test that you'd ask for? So feel free to vote. Okay. So again, MRA and MRI tend to be the more popular answers. So I'll just take you through where I think they wanted us to get to. So the diagnosis they were alluding to here was an arterial dissection. And if I just go back to the question, and I'm not going to lie, this is a tricky one, but they've described an acute neurological syndrome, which includes vertigo. And as we know, vertigo could point towards a central cause or a peripheral cause. And then but if you were thinking about if it was a central cause, any central cause of an acute neurological syndrome associated with neck pain should entertain a diagnosis of an arterial dissection. Now, if you saw this patient clinically, there'd be lots of questions around, he's so young, he's got no medical history, why is he having a spontaneous dissection with no real history of trauma? So I'd appreciate that, we could go off on a tangent here. However, they have added in the recent viral illness, and there have been case reports around viral illnesses preceding arterial dissections. But I think for the purpose of the exam, they just wanted you to think about, could this possibly be a central cause like a stroke in this case? And could it, because they've talked about neck pain, please do think about arterial dissection. So they just wanted to go in that direction. And they've given us just one positive neurological finding. And so therefore, it's testing the knowledge of interpreting this neurological finding as pointing towards that central cause of vertigo. And if I just take you through just in terms of if they did describe, so how do we differentiate within the question between, and I think clinically as well, this slide is relevant, central and peripheral causes of vertigo. You've got your history and neuro exam, and then the HINTS exam, which some of you may have come across, which is it's a bedside test, it's clinical, it's got 3 components and demonstrated to have quite high specificity and sensitivity in helping to differentiate between central causes like strokes, MS, brain tumors of prolonged vertigo, and peripheral causes like what we would see at the front door, labyrinthitis or acute neuritis, acoustic neuromas, etc. And it's the nystagmus bit that's probably worth going through, which I will do on the next slide because it's easier to ask in a question. But just for your clinical practice, I've put the video link there, and it's worth just going through, and it's quite a useful test when done by an experienced operator. So so again, just some bullet points under nystagmus. If they describe torsional or vertical nystagmus, that would make you point towards a central cause. And if they just describe that, you then take that into context and say, they want me to be thinking about, well, really a stroke in these conditions, because that's what you'd see more acutely. And if they describe horizontal nystagmus, so that could be a central cause or a peripheral cause. And with horizontal nystagmus, like this gentleman had, if your fast component changes with the direction of gaze, so for example, if he looked to the right and his fast component was to the right, and then he looked to the left and his fast component was to the left, like what was described here, that points towards a central cause. So if there was any doubt about the diagnosis in terms of what the acute neurological syndrome was, they then validated that in their second paragraph, saying, well, actually, he's got a positive neurological finding pointing towards a central cause, and he's also got neck pain, so let's entertain the diagnosis of an arterial dissection here when we're thinking about our next best investigation. And then if the fast component was in the same direction, irrespective of the direction of gaze. So for example, if he had a problem with his, he had right labyrinthitis, for example, he looked to his right, the fast component would be to the left. And if you look to the left, the fast component would stay to the left. So it would, the fast component of the horizontal nystagmus will stay in the same direction and usually away from the side of the affected ear in a peripheral cause of vertigo. So I think that slide is just worth knowing. And then to come to the actual answer, the guidance is from the RCP guidance and the NICE guidelines, which is if you are suspecting an arterial dissection, go for your next modality investigation should be angiography, and that could be MR or CT angiography. So there's quite a lot in that question. So just before I go to the next one, Nick, are you...
Everything's okay.
Yeah.
No questions that we need answering yet.
Perfect. Okay. So just again go to question 3. Okay, so 70-year-old vascular path who had sudden monocular visual loss on his left eye, a normal neurological examination, and his Doppler showed a 60% stenosis on the right and a normal flow on the left. So that should actually read 60% stenosis on the right side and normal flow on the left. So what's the next best investigation? About 10 seconds and then we'll go through it. Okay, so it's between ECG and carotid angiography. Maybe some for MRI of the brain as well. Okay, so it's going for an ECG. So I think we all got the diagnosis of amaurosis fugax of his left eye. So it was left monocular visual loss. And so I think then the questions testing knowledge on a little bit about arterial blood supply and then the RCP guidance around that. So with a stroke or a TIA, the guidance is, and in this case, it will fall under a TIA category, investigate patients for ipsilateral carotid artery stenosis, which he's had Dopplers for, atrial fibrillation, which would be with a ECG in clinic, so that's A. And then if there's any suspicion of a cardioembolic source or structural heart disease, to go for an echo. The echo in this question was a bit of a trick question, option, because they'd asked for transesophageal and not transthoracic, so it wouldn't have been an option anyway as anyone's first line. And then as to why we'd go for an ECG over angiography, that's the test a little bit around the arterial blood supply. So I'm just going to give a couple of general rules of thumb to just remember for the purpose of the exam. They're not going to expect you to know the entire circle of Willis at all, but just in terms of just remembering, the right internal carotid artery will supply the right eye and the anterior circulation of the right hemisphere, so the majority of the right cerebral hemisphere. And the left internal carotid artery will supply your left eye and your left cerebral hemisphere. So any symptoms that are from that part of the brain or that eye, you would be looking at any blood flow from that particular vessel. So for this chap, for example, he had left monocular visual loss, which is supplied by the left carotid artery, which we were told was normal. So at that point, you wouldn't go on to further investigate a vessel. You would only further investigate with a dual modality if you felt there was a significant stenosis. And they could ask you about that, which is why I've put the last 2 points. So what is significant? So over 50% stenosis is deemed to be significant in the symptomatic side. So for example, if he had 75% stenosis of his left internal carotid artery, we know that his left caused the symptoms because his left supplies his left eye, and therefore we would then look at the percentage, and it falls between 50 to 99%, and those patients would be deemed to will be warranted a referral for consideration of an endarterectomy. So they could have easily asked the question around that and given you a higher percentage. So it's just about remembering the left supplies the left eye, and then the left side of the brain, and the right supplies the right eye and the right side of the brain. Asymptomatic carotid artery stenosis. So his right carotid had a 60% stenosis, but that's on the asymptomatic side. It didn't give us any symptoms of the right eye or the part of the body that the right side of the brain controls, which would be the right arm and leg. And so therefore, and the recommended management for an asymptomatic carotid artery stenosis is best medical management. There's no evidence to suggest that operating on those patients would do more good than harm. So that would be around antiplatelets, blood pressure control, etc. So I hope that answered that question. So I think, so just going back, for this sort of straightforward TIA with a normal carotid on that side, you'd go for an ECG, and there isn't anything in the guidelines about then further imaging the brain as well, unless they gave you any other weakness or symptoms controlled by the brain, if that makes sense, whereas this was an isolated monocular visual loss with no limb or facial weakness. Oh yes, so so they could easily have said around they could have given you facial and limb weakness as well, and then asked the same question, and it's just remembering the sides. So the right carotid artery will supply the right eye and the right side of the brain. The right eye will give you right visual loss as a symptom. The right side of the brain ischemia will give you left-sided facial weakness and left arm and leg weakness. So it's just remembering the side of the carotid artery that you're looking at if the question describes arm or leg weakness or eye symptoms. And aphasia is pretty much one of the only clinical signs that you can then pinpoint to a certain territory that could be easy to ask in a question, and largely it's in the left hemisphere. So you'd be looking at the left internal carotid artery if they said the patient came with aphasia. So I just put up that, just again, it's about the exam. It's just about these general rules of thumbs, and it's very easy to then try and go into too much detail, but just for the purpose of the examination, just trying to keep it as simple as possible. Any questions on that, Nick? We'll move on to the next one. Okay, so just moving, so a young lady with some interscapular pain, and then on examination, she's got this sort of peripheral symmetrical motor sensory loss with no evidence of cord compression, for example, on her MRI spine. And the question is, what's the next most appropriate investigation? Okay. Wow, so almost evenly, yes, split. So big range here. And it is a complex question. There's a lot in it to tease out. So the answer here is the lumbar puncture. And the diagnosis that they were alluding to was either Guillain-Barré syndrome or something along the spectrum of Guillain-Barré. And I think it's just sort of thinking about entertaining the possibility of something along the spectrum of GBS in a patient, in a young, in a patient with symmetrical motor weakness. And I think that was the crux to take from the question. The other things that they added in to make it more complicated and different from standard MRCP question was they added in the atypical nature of it. So for example, up to 10% of such patients can have their reflexes preserved or even deep tendon reflexes exaggerated. Nerve conduction studies, as we know, can be non-diagnostic, as can the CSF, and we would end up repeating it, but that would still be our first line investigation, as with the high protein and the normal cell count would be diagnostic, along with the clinical picture. So just going, and again, it didn't describe, where's the question, sorry, it didn't describe our standard sort of diarrheal illness or preceding infection. And I just think it was just making the question a bit harder from the standard MRCP and just adding in the atypical nature of it. You can have pain associated with these syndromes, which are felt to be neuropathic pain or radicular pain, which is probably what she had. And of course, with some of the variants, you'll have the peripheral and the cranial nerve weakness, which again is what she had. Again, I think if it was a dissection they wanted us to think about, they would be a bit clearer. Everything was around neurology, her vitals were normal. I would think that the question would have suggested something along blood pressure, something along hemodynamic instability or trauma to suggest that. Again, they talked about nerve conduction. I think it's just being wary of the fact that nerve conduction studies wouldn't be the first line here. As they can be non-diagnostic. Lyme serology, the NICE guidance says to consider it in a number of neurological conditions. They initially describe it for quite generalized conditions, malaise, systemic symptoms, etc. But they also consider requesting it, and we would at the front door clinically, wouldn't we, in practice for patients with, isolated neurology. But I think it was just pointing us towards the symmetrical, peripheral, distal, motor sensory weakness, and then entertaining that diagnosis of the GBS type spectrum and going for lumbar puncture as the next most appropriate. So I agree it's not the most straightforward, but that paper is quite good at describing sort of the atypical features of it as well. I think I saw some questions come through, Nick, but I might have mentioned it in my. No.
There's one. It was someone was mentioning if she's got a cranial 7 defect, there's no mention of breathlessness. A C7 defect, there's no mention of breathlessness.
The what? Sorry.
So James has said if she's having a C7 defect, why is there no breathlessness? Basically, I think that's what he means.
So 7th cranial nerve palsy, so she would have had a facial droop. So not a C7.
No, it should be the 7th cranial nerve, but why is there no mention of breathlessness? I'm not quite certain what he's getting at.
Okay, well, hopefully they can always explain, and I can add something in the chat at the end. Fine, we'll go to question 5. Okay, so a young man with his first fit, no, otherwise normal exam, no real evidence of focal seizures. He's been given some driving advice. And the question is, what's the most appropriate next investigation? Again, the question's in the chat if you wanted to look back at it. Okay. Fantastic. So yeah, it's an outpatient MRI from the brain, so that's quite straightforward, and it's taken straight from the NICE guidance, which is in a first fit with no other worrying symptoms of an acute neurological illness or a focal seizure, which they were very clear to tell us there wasn't. If their ECG is normal and there's no other suspicion of cardiac syncope, then you would investigate them neurologically for structural abnormalities of the brain. And they've specified that would be by means of an MRI as an outpatient. And they've described the general consensus being outpatient as a reasonable time of 4 weeks. With an outpatient EEG as well. And inpatient imaging would be around, again, acute neurological illnesses, fever, etc., or anything to suspect a focal etiology. So I think most of you got that. The other thing I've put in was around the driving guidelines. So that's the gov.uk guidance for medical professionals as to what we would advise. It's quite a long list. You will not need to know all of them, but if there were anything that you were going to go through for the purpose of the exam, I would go through stroke, syncope, the two purple ones, and then epilepsy and seizures. And they sort of look something like this. The car licenses and the bus and lorry license. So he sort of fell into this category, but they could have easily asked around what would his driving restrictions have been. And I think I would just focus on just having a quick look at those three. And I really don't think you'll be asked about anything else if they were going to ask you about driving at all. Okay, question 6. Okay, so relatively young man, severe headaches, describes unilateral excruciating associated with eye signs. And over the last couple of days, he's had sort of a cluster of them. And the rest of his examination was normal. And what treatment should be prescribed next? Okay. Yeah, fantastic. Okay, that's exactly it. So the NICE guidelines for headache talk about cluster headaches, migraines, tension headaches, and the diagnostic criteria for each and their recommended management. The NICE for cluster headaches are around high flow oxygen, adding in they had the option of subcutaneous triptan, which wasn't incorrect, but it asked about the next best. So you'd start off at least with high flow oxygen and then reach for your triptan. I guess there's a little bit of testing here around what to avoid, and that rapamil is more of a prophylactic agent, but all of you got the high flow, so that seems quite straightforward. So our last question.
Annika, there's a question for the last question. Perhaps you go back at the end and have a look at it.
Okay, I'll try and open it now while they're reading. Okay, I'll move on. So, they're asking about a 50-year-old lady. They've put acute confusion in inverted commas, and then actually describe what we actually found, and that she was quite repetitive. She had a period of amnesia. She'd had a potential trigger of stress, and everything else appeared normal. So what's the most appropriate management? Nick, I can't actually see the questions on the chat, so what I'll do is I'll look at them at the end, I suppose, because I can't seem to open the chat. Okay, so just so yeah, exactly. Sorry, I just realized that I might have been opening the chat in the middle of my screen. I apologize if that's the case. So yes, so I think everyone got, the majority of you got what the question was alluding to. TGA. I've just put through on the slide here. I think you'll all be sent these slides, but it's a clinical diagnosis. There's a diagnostic criteria described. The question will be quite straightforward, I would imagine, if they want you to go for this diagnosis. Everything else seems fine. They very classically appear repetitive, very classically can't store memories, and they will get better in front of your eyes. It's fairly short-lived. And I think it's around management of the patient would be around observation and reassuring the patient that it's a benign condition. Radiologically, studies have shown, so the hypothesis around etiology of TGAs are around ischemia to hippocampal, mesotemporal structures of the brain, which are responsible for storing and creating memories. And studies have shown around mostly between day 7 and 14 after the event, restricted diffusion in these areas. But actually, a negative MRI doesn't really help you when you see these patients in clinic or at the front door 24 hours or within their episodes. And that's why I wouldn't pick MRI as an investigation perspective, although some trains of thought would be using that as part and parcel of an investigation. But here they just sort of wanted how you were going to manage the patient. And I think most of you went along the lines of reassuring the patient that it was a benign condition, which is the right thing. And that's it from me. So I think I did manage to find the chat, and I was going through it, but I didn't find any other questions unless you did, Nick.
We've been typing some of them answers as we go. There's just one left in the Q&A for you.
Oh, okay, separately. Okay, I'll do that.
Thanks a lot. I know it's a short straw every single time to do this horrible topic. You're on what I understand least of. But thanks again for all your help, and we'll see you in London.
Well, no, I'm having a baby next week, so.
All right. Good luck.
But good luck to everybody, and I hope everyone does really well.
Thanks a lot. Thanks for all your help.
No problem. Bye.
And moving along, our next speaker is Dr. Andy Hardy. He has been an acute physician for over 10 years, but now he hides in respiratory medicine. So over to Andy for his questions. Thanks, Andy.
Hi. Thanks. Yeah, and thanks, Annika. I thought that was really good, actually. So I've been listening in, and a few good tips there for my next general medicine on call. So yeah, I think I've got control. Have I got control? Yeah, okay. So yeah, so I'm a consultant in respiratory medicine. These are the sort of things that might come up which are respiratory focused in the current AIM curriculum. So we'll cover a few of those in the example questions that we've got. These are the common conditions. So the sort of things that, I mean, obviously you'll be aware the sort of things that come up commonly in acute medicine of COPD, asthma, pneumonia, a little bit of pleural disease. Respiratory failure is obviously very common at the moment. PEDVT, TB, we probably don't see a huge amount of in acute, if I'm honest. Again, obstructive sleep apnea, we generally treat as an outpatient condition. CF I'd considered generally only in the tertiary centres, to be honest. COVID's not quite made it onto the curriculum yet, but obviously oxygen delivery and respiratory support and things like that are the sort of treatments for COVID. So maybe that'll be in the curriculum in a few years' time. Who knows? So, and these are the sort of common respiratory investigations that might come up. Obviously, there's a session on radiology coming up next. Pleural fluid analysis and speech and cultures, you're probably going to be requesting those quite often. Lung function tests, we wouldn't necessarily be expecting people to be sort of interpreting complex lung function, full lung function and CPEX and things like that, but certainly spirometry and peak flow, you probably need to have an understanding of. Obviously focused ultrasound is becoming more common, so in terms of managing effusions and things, I think that's probably going to become more of an acute medicine thing over the next few years as more people get trained in ultrasound. Again, bronchoscopy, I think you'd be quite unlucky to get something bronchoscopy related in an acute medicine exam, but it is in the curriculum. So first question then. So not an uncommon presentation, 64-year-old man with fever, cough and purulent sputum. Those are his observations. Oh, sorry, Alison, do you know what the code is for the Menti? Was it on the first slide? Yeah, sorry. I'll just leave that there for a moment so people can log into the. Okay, so I'll go back to the question. Oh, do I need to hide the? Yep, sorry. So yeah, if you haven't seen the Menti code, it's it's the one beginning 964. Alison's put it in the chat. 96463415. Yep. Give it another 10 seconds. We've got nearly 40 answers in. Okay. Fine. So the vast majority gone for blood pressure. Yep, so we're not catching anybody out here. So yeah, pneumonia. So it's very common, obviously, presentation on acute medicine units. The BTS guidance is actually quite old now. I don't think there's been much new come up in pneumonia in the last few years. Curb score is obviously the system we use to assess pneumonia severity. I think it's quite a reasonable question. They may ask about management based on curb score. So BTS, the curb score 0 to 1, usually we'd be recommending outpatient treatment with oral antibiotics. Curb score 2, we'd be recommending admission for treatment. And curb score 3 to 5 is severe pneumonia. So ideally managed in a high dependency area with intravenous antibiotics. Other things they might come up in the guidelines is investigations. So obviously chest x-ray within 4 hours, routine bloods including inflammatory markers as a baseline is reasonable. Culture everything, so sputum, blood cultures. In severe pneumonia you can do urine for Legionella and pneumococcal antigens. They might ask about non-antibiotic treatments, so that's things like VTE prophylaxis, physio, oxygen, smoking cessation. Potentially they'll ask about follow-up. So that would be, usually we just do a chest x-ray in 6 weeks. And you don't normally need any additional imaging at the initial presentation. Usually the chest x-ray is sufficient. So as I say, the BTS guideline is quite old now, but it's a fairly common condition, so I think most people are fairly good on that. And yeah, most of you got the answer right, so that's good. Right, on to something slightly different. So young lady, more chronic symptoms, possibly treated, partially treated for TB in the past. And these are her initial investigations. Alison's just putting that information in the chat. So what's the most appropriate initial management? Yeah, so I'll give you another 10 seconds. Okay, very good. So again, large majority in favour of negative pressure isolation, which is the recommended answer. So I think I have to say I think it would be a little bit harsh to get TB in the exam. It is in the curriculum. Even in respiratory, it's considered to be a sort of subspecialty interest, but and it's not that common for it to present acutely like this. But yes, it's reasonable to know the initial management steps. They're probably not going to ask you too much about other treatments. Investigations would be, again, chest x-ray. You might consider a CT scan if there's an abnormal distribution of consolidation on the x-ray. Again, culture everything. In terms of the sputum, you send 3 morning cultures for acid fast bacilli. You'll get the gram stain, but it did mention the gram stain in the sorry, not the gram stain, the ZN stain in the question, and you will get that back fairly quickly. But obviously, the cultures can take up to 6 weeks, so it can take a while to diagnose sometimes. Occasionally, you might see MDR TB. So the risk factors here are obviously partial treatment of TB previously, somebody's been treated abroad, history of alcohol or drug misuse, and obviously if there's any concern about drug-resistant TB, then the person should be isolated. I don't know if it was, I'll give people the benefit of the doubt, but obviously if it's a positive pressure room, that will be blowing the organism out of the room into the rest of the ward, which probably isn't a brilliant idea. Quantiferon is a sort of antigen test for TB, so it's not useful in diagnosing active TB. We use it to generally screen for latent TB in new arrivals to the country. It's usually not a good idea to start anti-TB treatment until you've got some cultures back, and particularly if you're concerned about MDR TB. If you start treatment early, it might lead to further complications down the line due to the drug resistance and further partial treatment. So I generally wouldn't recommend that. It's better to get a diagnosis first if you can do. Obviously, the initial step is to isolate the person to stop anybody else getting it. If you are going to treat, we treat with 4 antibiotics initially for 2 months. So rifampicin, isoniazid, pyrazinamide, and ethambutol would be the common combination. But as I say, if there is a concern about drug resistance, then you're usually better waiting for the drug resistance screens to come back first. just because there's a risk that if you partially treat somebody who's already got multi-drug resistant, it can go to an extended resistant. Well, you say that, we do actually have negative pressure rooms on our acute floor in Calderdale. Yeah, maybe they're not available everywhere, but if they're not, then obviously the recommendation is that you would transfer to an area that does have them as quickly as possible, and all respiratory units should have negative pressure rooms, even if the acute floor doesn't. But yeah, I agree. There's sometimes there's a difference between real world practice and the exam answer, but that is the preferred answer in the exam. As I say, I think you'd be a little bit unlucky to get TB in the exam because you probably don't see it that commonly in an acute setting. But the nice guidelines there, NG33, if you didn't want to have a look at it. Yeah, so we talked about TB. Sorry to everybody who lives in London, but yeah, there is more MDRT, just probably because there's more people with risk factors in London. I don't think being in London itself is the particular issue. It's the fact that there's a higher instance of other risk factors for MDR-TB for people living in London. Right. So, yeah. Next question, 65-year-old lady, high BMI, non-smoker, and that's her initial blood gas. Give it another 10 seconds. Yeah, okay. Very good. So you're doing very well here. So maybe you don't need to put the respiratory session on next year. Yeah. So congratulations to anybody who's read the BTS oxygen guidance. So this is quite an interesting document because it's been agreed by so many different specialty organisations, but unfortunately it's over 100 pages long. So I suspect most people won't get a chance to look at the whole thing. The basics of it are that if somebody's critically unwell, we just give high flow oxygen and worry about the consequences later. In people where you want to go for target saturation, if there is a history of type 2 respiratory failure or previous NIV use, or conditions that might predispose somebody to be at risk of developing type 2 respiratory failure, then we'd go with a target sat of 88 to 92%. So obviously in this case, you've correctly interpreted the blood gas, which showed a high partial pressure of CO2. For everybody else, we'd go for a target saturation of 94 to 96%. And obviously it's important that you're prescribing the target saturation, not the delivery device. So other risk factors for type 2 respiratory failure, so moderate to severe COPD, long-term oxygen use, kyphoscoliosis, any sort of neuromuscular diseases, overdose of sedatives or narcotics, and obesity, as is the case here. So again, I think that's a fairly straightforward one, and most of you got the right answer there, so that's good. So you can put questions in the chat if you wish. So hopefully we'll have a few more tricky ones coming up, which might encourage a bit more discussion. So question 4 then. So we've got 74-year-old man with pleuritic chest pain, previous cholecystectomy, fever, tachycardia. Yeah, so just go 86 to 88% is just a sort of red herring. The 88 to 92 is, yeah, it's not a genuine target range that we'd use, 88, 86 to 88. So this is the X-ray. Oops. So this is a, hopefully you can see that. What I'll do is I'll just show you the answers and then I'll come back to the X-ray because you might need a bit longer to look at it after you've seen the options for the answers. So we've got free gas under the diaphragm, pneumothorax, pleural plaques, right lower lobe collapse, or pleural effusion. So I'll just go back to the X-ray before you might need to have another look at it before you do your answers. Give you another 10 seconds for this one. So okay, so I've got sort of 50-50 pleural plaques and right lower lobe collapse. So again, the history is a bit of a red herring actually. The answer is pleural plaques. So we'll go back and have another look at it. So it's a little bit sneaky because actually the sort of history doesn't have anything to do with with the actual diagnosis. So so just to run through them. So obviously air under the diaphragm, you would see, you know, sort of black areas down at the bottom here. Pleural effusion, you'd see a loss of the hemidiaphragm with a sort of homogeneous white shadowing that tracks up the pleura. So you haven't got that. Pneumothorax, you'd obviously be able to see the lung edge, and you'd lose the lung markings beyond the lung edge. So that's not there. So what did it say? Right lower lobe collapse, or yeah. So right lower lobe collapse. So what essentially that will collapse down into a triangle essentially. So you'd lose the right hemidiaphragm, and then the lobe sort of pivots on the hilum, so you get a sort of triangular density down on the right side. Now, left lower lobe collapse is a little bit more sneaky. I don't know what Nick's got in his slides later, but the problem with the left lower lobe collapse is that the lung collapses behind the heart, so it's quite easy to miss. So you'll get a triangular density behind the behind the heart, and you'll lose the medial aspect of the left hemidiaphragm. So left lower lobe collapse you can miss, so it's something you need to specifically look for. With a right lower lobe collapse, essentially because the heart's not in the way, you should see the lung edge and you'd lose the hemidiaphragm. So what you've actually got is this sort of well circumscribed, sort of ovalish. Yeah, so somebody says, is the volume, there is possibly a little bit of volume loss at the apex possibly, but you haven't lost the right hemidiaphragm, you haven't lost the heart border, and there's no triangular area where you'd see the collapsed lungs. So the abnormal area is this sort of well circumscribed, calcified, it's sort of similar density to bone area in the pleura. It doesn't really match with any anatomical structure, so that's a pleural plaque. So as I say, it's a bit sneaky because obviously with the history you're probably expecting to see a pneumonia or perforation or something, but actually the x-ray doesn't really match up with the clinical history. So yeah, so the answer is pleural plaque with that one. And as I say, Nick's got a radiology session coming on. So the things to look out for, don't forget to look at the hilum. They can sometimes hide stuff in, hilar lymphadenopathy, things like that. Check under the diaphragms for free air. Check the soft tissues. If occasionally they might put, surgical emphysema in or something like that in somebody with severe asthma. Yeah, well, unfortunately, yeah, I don't think there's certainly I don't think there's anything above the diaphragm, which is it didn't actually ask what the next plan was, but it sounds like it's a complication of the cholecystectomy, doesn't it? So yeah, probably. So yeah, they'll probably say you need surgeons will probably say you need to follow up for the pleural plaque, but actually they don't need any follow-up. So but as I say, so the 5 areas to look: if the x-ray looks normal initially, look at the hilar, look at the soft tissues, look under the diaphragm, look at the bones, check there's no fractures or anything, and look behind the heart. Essentially, sometimes you'll see a labor collapse or a large hiatus hernia or something. But I'm sure Nick will probably go into that in more detail in the radiology session later. Yeah. Yeah, that's it. Okay. Right, I've got 3 more. So again, COPD is a fairly common presentation on the acute floor, so I think it's reasonable to ask about COPD. So recurrent admissions, currently treated with salbutamol and confirmed airflow obstruction on spirometry. So what's the best first treatment? So we've got 30 answers in. I'll give you another 10 or 15 seconds. Still getting a few answers in. Okay. Right, so I quite like this question, so we'll see what people have come back with. Oops. Show the results. Oh right, okay, yeah. So you've done pretty well there, actually. Fine. So there has been quite a lot of movement with COPD treatment over the last sort of 10 years or so. There's been quite a lot of new treatments come out, and there have been some significant updates to the guidance. So the most recent NICE guideline was updated in 2018. So you'll be aware, historically, we treated a lot of people with inhaled steroids, but there's been a move away from inhaled steroids recently. And the preferred treatment option these days is dual bronchodilator therapy. So that's antimuscarinic plus a beta agonist. So that's things like, you might be aware of Anoro, Ultibro, Duaclear, those sorts of things. So inhaled corticosteroid on its own, we would generally only use in asthma, and in fact it's sort of going out of favor in asthma as well these days, so that's not really an option. As I say, the historical treatments were LABA ICS, so that's your combination inhalers, things like Symbicort, Foster, Seretide, and as I say, the sort of evidence base has been growing recently, and what we're saying now is that we would only use corticosteroid in people who've got asthma symptoms that suggest a combination of asthma and COPD. So that would be things like earlier age of onset, non-smoking, other atopic diseases like hay fever, eczema, those sorts of things. And eosinophilia on the full blood count. So 10 years ago, the answer would have been LABA ICS, but obviously, as I say, things have moved on a little bit since then, and now we're recommending LABA LAMAs. The other sort of another effective treatment is pulmonary rehab, and actually pulmonary rehab is a more cost-effective treatment than inhaled therapies. But the current recommendation is that is recommended for people who have an MRC score of 3 or above. So that would be people who are sort of more significantly limited in day-to-day activities, have to rest if they're walking on the flat. So I think this is quite a good question in that you have to know what the MRC rating is, and an MRC of 2 would be breathlessness on heavier exertion, such as climbing hills or rushing. So this gentleman's MRC 2, which means that the pulmonary rehab isn't recommended as first-line treatment for him. So you would go with LABA LAMA. For people who've got more limiting breathlessness, pulmonary rehab is a more cost-effective treatment. So that would actually be the preferred option ahead of inhalers. So it's a bit counterintuitive, actually. The other things that are worth asking about COPD, so smoking status, seasonal vaccination. It's recommended that everybody has a self-management plan and that comorbidities are managed properly. And as I say, the sort of things that might come up, other good sort of exam questions are distinguishing between asthma and COPD, spirometry and blood gas interpretation may well come up. So knowing spirometry is basically being able to work out the difference between restrictive and obstructive spirometry. So that's, obviously looking at the FEV1 to FVC ratio, less than 70% is obstructive. Indications for non-invasive ventilation, because that's something that you're going to be seeing quite often on the acute floor. So again, that sort of comes down to blood gas interpretation, and the indications for NIV will be people with acidotic type 2 respiratory failure, so PCO2 over 6 and a pH of less than 7.35, which doesn't respond to initial treatment with optimization of the saturations, nebulized bronchodilators and steroids. So again, just watch out if they're asking an NIV question, because they might say, do you start NIV immediately or do you wait an hour after you've started other treatments? And then management of acute exacerbations hasn't really changed much in the last few years. The only thing that they're suggesting now is slightly shorter courses of steroids and antibiotics. So the most recent guideline update was 5 days of antibiotics and steroids is sufficient for an acute exacerbation. So that could potentially come up in an MCQ. So well done for everybody who got those right. Nothing come through on the chat about COPD, so we'll move on to the next one. Okay, yeah, I'll come back to the question about guidelines for asthma in a moment. So the question is, how severe is the exacerbation? Oh yeah, Alison, could you drop the question into the chat? Thanks. So we've got over 30 answers. I'll give you another 10 seconds and then we'll go to the answer. Okay. So we've got a little bit of variation, but the balance of opinion is for life-threatening, which is correct. So yeah, the key here is the near normal PCO2. So the other sort of markers of severe would be you're looking at respiratory rate, peak flows, silent chest is a poor prognostic sign, and the guideline that we're referring to here is the BTS sign guideline. So this is slightly out of date because it was updated. I think we're up to 158 now, but it hasn't changed massively. Most of the changes are talking about the management of sort of stable persistent asthma rather than the acute exacerbations. So again, it's a pretty long guidance. It's about 200 pages, the whole thing. So we wouldn't be expecting people to read the whole guideline, but there are some, if you did want to look at it, the appendices are quite good and they've got some very nice one-page summaries of different aspects of asthma management, and there's also a quick reference version as well. So as I say, I would suggest certainly look at the appendices, because that gives quite a nice summary of the guideline. I don't think you'd really need to look at the whole thing, but it has been updated recently. So there was an update in 2019, but that was, as I say, generally focusing on the management of stable asthma. So severe asthma, as we say here, I think this is actually the life-threatening asthma symptoms, isn't it? Altered conscious level, silent chest, normal PaCO2. So again, I think asthma is very, pretty common presentation, and it's quite a straightforward MCQ to make something up based on the difference between severe life-threatening asthma and things like that. So I imagine that's quite a common question to come up in the exam. I'd say other things that might come up related to asthma, they might ask about management. So the sort of management of long-term of chronic stable asthma now is focused around combination treatment with LABA ICS inhalers. So that's as I say, the combination inhalers, sort of like Seretide, Symbicort, those sorts of things. Again, it might come up about the clinical. So asthma is generally a clinical diagnosis. So they might ask about differentiating between asthma and COPD and symptoms. And as I've said, that's things like age of onset, so age under 40, non-smoker, atopic illnesses, family history of asthma, and particularly if they've got non-exercise related triggers, so like dust, pollen, aerosols, deodorants, those sorts of things would suggest asthma. And diurnal variation, again, is another sort of classic symptom of persistent asthma. So that might come up. Again, the management of an acute exacerbation hasn't really changed that much. So it's nebulized bronchodilators, salbutamol initially. You can repeat salbutamol after 5 minutes and then add in a LAMA, so ipratropium, if they need a third inhaler. You can give the steroids intravenously in severe or life-threatening asthma, and early decisions on escalation and involving other specialist teams. So as I say, it's quite a common condition. It's one that sort of lends itself quite nicely to MCQs. So I would suggest having a quick look at either the quick reference version of the guideline or the appendices, because they do give quite a nice summary of the management, clinical features of severe and life-threatening asthma and the emergency management. And so we've got one question left. So this is I'll let you have a look at it. This is the one that provoked the most debate last year. Oh. We'll pop those in the chat. So what's the most appropriate next test? Another 10 seconds. Right, so, okay, so again, we've got a bit of a split between CTPA, Doppler echo and D-dimer. Yeah, so a little bit of, obviously the neurology session was previously, so obviously nobody's gone for MRI, despite the fact they've collapsed. So what's the that's the correct answer then. So the guideline answer is CTPA. So the difficulty with PE in pregnancy is that there are a number of different guidelines. So BTS have got a guideline, the European Society of Cardiology have got a guideline, and the Obs and Gynae, which is the one that's referenced here, have got a guideline. They generally say similar things, but they're not quite exactly the same. So I'll just run through the different options. So they all agree that D-dimer is not indicated in pregnancy because you can have, obviously pregnancy can cause an elevated D-dimer. Now, I agree in real life, we may well do a D-dimer because if it's normal, it's helpful. But the guideline says don't do it because it doesn't help, you know, it's got a low positive predictive value. Echo, we wouldn't generally do an echo if we're investigating for PE as a first line investigation. So the reason you would do the echo is to assess for right ventricular dysfunction, because that may change your initial management, but we don't generally use it, even though it's a non-invasive test and doesn't involve any radiation, we wouldn't use it in the initial diagnosis. I think they put that in because there's this history of collapse and tachycardia, but I think the idea is it's pointing you towards a sort of PE and how you'd investigate PE. So it comes down to CTPA or Doppler ultrasound. So the guideline basically is that they wouldn't recommend doing a Doppler ultrasound unless there is clinical evidence or clinical suggestion of a DVT. So again, although in real life you might do a Doppler because it saves you the radiation, and if they've got a DVT then you can treat it. The guideline answer is that if there isn't any clinical features of a DVT then you wouldn't do Doppler. So, and obviously in the question there was a bit about the legs appearing normal. So we had a bit of a discussion last year about whether VQ or CTPA is the preferred investigation. So historically they used to say VQ was preferred because essentially because it delivers a lower radiation dose to the breasts, but the current recommendation is that, as you've said, is CTPA, and that the thinking here is that the modern scanners, the low dose scanners, actually the radiation dose is quite low. So, and obviously they haven't given you the option of VQ here, which is why you know, it's not the answer. Yeah, I mean, yes. Again, chest X-ray is helpful and is recommended, but it wasn't one of the options. So it would be a more interesting question if you had an option of chest X-ray, VQ, or CTPA. So the RCOG guideline is they hedge their bets essentially. So they say that there isn't a problem doing CTPA, but the preferred investigation should be based on local availability. And actually, for most people, it's easier to get a CTPA than a VQ or a perfusion scan. ESC, so the European Cardiology Society, say that they think CTPA is the preferred option. And although there is a slightly higher dose of radiation, it's not felt to be, you know, clinically significant in terms of the additional radiation dose with the modern scanners. And BTS don't say either. They don't give a preference. They say that either can be used, and that they don't say anything. So the RCOG do say it depends on local availability. But obviously here there wasn't an option of VQ, so you have to go with the best answer, which in this case would be CTPA. But again, it's a little bit difficult because there are a number of different guidelines. Now, if you're keeping an eye on the chat, there was a question earlier about if there's a number of different guidelines, which one do you go with? And Nick said that generally, if there's a NICE guideline, that's the preferred one to look at. And then secondly, you'd generally go with the specialty specific guideline. But the difference here is that it's whether you think PE in pregnancy is a respiratory specific problem or an obs and gynae problem. And I think the reality is that most of these people end up coming through medicine. So kind of EQ showed right heart strain? Not really, no. You'll see you can see features of right heart on strain on a CTPA. And one of the reasons ESC go with CTPA is because it does show other conditions, so it'll pick up pneumonias and things like that as well. In terms of, so features of right heart strain would be right ventricular, dilated right ventricle, deviation of the septum to the right side. You can get reflux of the contrast into the IVC, and you might see an enlarged pulmonary artery. So if the pulmonary artery is bigger than the aorta, that's abnormal. So yeah, you can see features of right heart strain on a CTPA, but VQ wouldn't do that. In terms of the fetus, so again the radiation dose is very slightly lower for a VQ scan, but it's not, the difference is minimal. The difference really is in the radiation dose to the breast, and again in the ESC guideline there's a nice little table that shows you what the radiation dose is, and it is about 5 to 6 times higher for a in terms of the radiation dose to the breast. But ESC feel that the advantages that you get with the additional clinical information and the fact that even though the dose is higher, it's still not felt to be sort of clinically dangerously higher. They still feel that CTPA is the preferred scan. Yeah, she's collapsed, so she's high risk. So you would want to know about right ventricular strain, but you've got to confirm that she's got a PE first, because obviously you wouldn't give treatment for PE without knowing. So echo would be a reasonable test once you've confirmed that the patient has a PE, but obviously you have to confirm that they've got PE first before you do further investigations. And yeah, VQ wouldn't be appropriate in anybody who's got an abnormal chest X-ray, but I think the question did say that the X-ray was normal, didn't it? Yeah, it was on the second slide. So yeah, so that's quite an interesting question. Actually, I think in real life that probably does reflect real life to some extent, in that actually sometimes managements of these people can be a little bit challenging. So as I say, there's probably a clinical argument for saying some of these other tests are reasonable to do, but it comes down to, if you only get to choose one, which is the best first test. And yeah, that's why they've gone with CTPA here. Yeah.
Our radiologist added a comment.
Yes, yeah. Again, you might debate whether the treatment of the small peripheral PAs is helpful or not. Any other? So that's the end of the questions. Have we got a couple of minutes, Nick, or is that, have I had my time?
That's about it. And there's no other questions in the boxes anyway. You've covered everything as it's gone in a wonderful fashion.
Okay.
You've multitasked brilliantly, picking up the chat as it went.
Tried to. So yeah, hope you all have a good evening, and hopefully we won't see any of you again next year.
Thanks, Andy. It was great.
Cheers. Thanks a lot.
So now everybody will give you a quick 5-minute, literally 5-minute DVT prevention break before we go on to our last talker, Nick Heppenstall, for our radiology session. So 5 minutes, back by about 6-7 minutes past 8. Welcome back, everybody. I hope you just stretched your legs, preventing those DVTs. We move on to our final speaker of this evening's session, Nick Heptonstall, a radiologist from Manchester. He's a first-time speaker, so be very kind to him. Thank you, Nick.
Thanks, Nick. Yeah, thank you very much. So I'm Nick Heptonstall. I'm an interventional radiology registrar, currently a senior fellow at Christie. Essentially, from a learning resources point of view, these three resources are exceptionally good. Radiopedia is essentially the Bible of radiology, and it's a great reference because it's got lots of examples for lots of different cases. The other two books are partly written by a chap called Lawrence Berman, who's an ex-colleague of mine, and he used to report 65,000 plain films a year, so it's got really good teaching points from his experience in that. So looking at the guidance online about the x-rays that you'll get, there's been lots of questions previously about the quality of the images and the fact that you can't edit the images from zooming or windowing. But it states very clearly that we do deliberately not include questions that require images to be manipulated, as we are aware that this function is not available. So all of the types of X-ray images that you're going to get, or CT scans, in the exam are probably going to be barn door cases. So if you're trying to window small, subtle findings, then there's absolutely no point. So for this, I'd recommend turning your screen right up when we go through the x-rays and some of the CT scans. So through this group of PowerPoints, essentially, I'm not going to do the whole voting, partly because I think it would be helpful to get through more cases of sort of more classical Aunt Minnie type cases. So essentially, just quickly to run through a chest x-ray, a system is essential for reporting a chest x-ray. I do the same thing for every chest x-ray that I report. And I do that to try and prevent me missing things in areas that I know are common areas that can be missed. So to just run through very simply, I always go through the right lung first. I then look below the right hemidiaphragm to look at the part of the lung that extends below the diaphragm in the recesses. I then go down the left lung, do the same below the left hemidiaphragm. Sorry. Thank you. And then go down the center, so trachea, look at the bronchi, then look at the cardiomediastinal contours, then look behind the heart along the spine. I then look at the soft tissues, the apices, down the lateral borders, and then I just follow all of the bones to make sure there's not something within any of the bones. Now, review areas are something that you formulate over time, but there are common areas that get missed. So discrepancy meetings, chest x-ray, it's always these 5 areas. So apices, hilar, behind the heart, and below the lung, below the diaphragm. It's always these cases, and you can easily prevent them from just spending more time looking at these areas. So silhouette sign is essentially the most important part of reporting any x-ray, including chest x-rays. So this is looking at important anatomical areas that are formulated by the difference of soft tissue density. So here you have an air interface against the right paratracheal stripe. Other structures that are important, obviously the hilar, as just mentioned, the aortic knuckle that comes around here. Sometimes you can get subtle soft tissue lesions in this window, just in here, or along the AP window, which is part of the pulmonary trunk. And then looking at the cardiac, this line along here is essentially formulated by the pleura at the back, which touches against the esophagus. So sometimes if you have an esophageal mass, you'll get this line can disappear. So it's subtle signs. So here on the right side, you can see that we've lost the right heart baller in a lingular consolidation. So we'll just go through some examples of cases. So essentially, I'll give you kind of 10 seconds or so just to look at the case and see what you think. And then I'll talk through it. So clearly there's an abnormality in the right upper zone. The key feature here is that, yeah, sorry, just as the comments say, there's no, yeah, I'm not using the voting system simply because then we can get through the case, more cases. So in the right upper zone, there's an opacity which is very clearly demarcated. So there's a very clear, crisp line. The right hilum does not look normal. You cannot see the vessels as clearly as you could before, particularly the right lower lobe pulmonary artery is not in its normal place. It's normally down here. And then we can see the right diaphragm is elevated compared to the left diaphragm. So this is right upper lobe collapse. This is classic right upper lobe collapse. Usually looks very similar. There's also on this X-ray some very subtle surgical clips and some irregularity to the left breast. So she's had some left breast surgery, which makes it very suspicious for this being an underlying tumor. So on the CT scan, this is just basically to show you what the two look like. You can see how you've lost the air interface soft tissue with the right tracheal border, which is why it looks very difficult to kind of see it in this area. There is still some aeration at the apices, which again, you can't really see on the X-ray. So right upper lobe collapse. So next case. So again, there's another area of abnormality. There's an opacity in this kind of right lower zone. So the key here is the fact that you can't see the right heart border. So you've lost that silhouette sign of the right heart border. There's a very well demarcated, just remove that, very well demarcated lines on either side. And then there's some tenting of the diaphragm. Again, the right diaphragm is a little bit higher. So this is right middle lobe collapse. So they may show you a lateral X-ray, which is something that a lot of people get very worried about, but they're actually very simple to report. So this is the classic appearance of a right middle lobe collapse, and it's over the heart border. So this is the heart in this area coming all the way around here. So anything typically that's contained within the heart is a middle lobe abnormality. Anything above the heart is upper lobe. Anything below the heart is lower lobe. So just to put it in a schematic appearance. So again, anything above the heart is upper lobe. Anything below the heart is lower lobe, and anything typically around the heart area is middle lobe. So we can see if we go back, clearly this is in overlying the heart contour. So this is a middle lobe collapse. Next case. So on this case, again, in the right lower zone, there's an opacity which impacts the visualization of the right heart border. Most importantly is the fact that you've lost this right diaphragmatic border. So this is a classic right lower lobe collapse. So the key here, the difference between the two of right middle lobe and right lower lobe is that you lose the medial aspect of the right diaphragm. So this is right lower lobe collapse. So this is another example of a right lower lobe collapse. Sometimes they can look an absolute mess, and you don't get that very nice straight line, but typically you've lost that medial border of the right diaphragm. So again, another example of right lower lobe collapse. In this case, it was a trauma case. They've got some fluid that's extending along the fissures. You can see the fluid in and around here. There's some gas within the pleural space, and there's a chest drain which is curled around here, coming out to the side. So next case. So this is more of a diffuse abnormality in the left side. We can see that there's this slight increased density of the left lung. There's an element of some volume loss, but not that much compared towards the right side. What you've lost is the complete left heart border. You cannot see it at all. There's also an area close to the aortic knuckle, which appears hyperlucent. So this is a classic left upper lobe collapse. So there's two signs of left upper lobe collapse that are specific to left upper lobe collapse. And one of them is Luft-Sickle sign. And this is essentially this area of hyperlucency adjacent to the aortic knuckle, which is essentially increased aeration of the superior segment of the left lower lobe. And that's where you tend to see it. And then what we're seeing on the left side is something called the veil sign. It's essentially where you're losing the penetrance of the X-rays through the left upper lobe. And it's said to look like a veil. And obviously that's the most famous veil that I could find on the internet. So on a lateral view, again, going back to our schematic diagram of what left upper lobe collapse looks like, anything above the heart in this area is an upper lobe collapse. In terms of determining whether it's a left or right upper lobe, it's impossible to really tell on a lateral film alone, but you'll usually have an AP or PA chest radiograph to go with it. So, I mean, the quality of this image is pretty terrible, but I think the finding is visible. So, like I said, if you're struggling to see something and you're trying to want to zoom, then you're not seeing the finding. So, in the left lower zone, there's a very straight line coming down here. You've lost some of this medial border of the left diaphragm. And then there is an opacity below the heart border coming along here. So this is left lower lobe collapse. So as was mentioned earlier, this is called sail sign. So it's a typical sail. And you get this very straight line over the heart border, and that's left lower lobe collapse. Sometimes the left lower lobe collapse can be really difficult to see, particularly if the collapse is exactly in line with the left heart border. But the clue is that you've lost this medial border of the left diaphragm. So this again is another example of left lower lobe collapse. And that's what it looks like on CT. So this is a MIPT image, basically lots of CT images added up. And you can see all the vessels within the collapsed segment. It looks quite high attenuation. That's because all of the pulmonary vasculature is still perfusing the collapsed segment, but there's no air within it. So these are two different cases. So I'll give you a little bit more time to look at these two. So clearly on both of these chest radiographs, there's an obvious abnormality, but they're subtly very different. So on the left image here, there's clearly a large area of whiteout. Now the key between these two X-rays is the position of the trachea. So on the left image, the trachea is pushed away from the side where the whiteout is. And on the left side, sorry, the right side, I'm thinking radiology, left and right. So on the right side, the trachea is pulled towards the whiteout. So in the scenarios where the trachea is pushed away, that's something causing mass effect on the trachea. And that's typically a massive pleural effusion, some form of mass, or things like diaphragmatic hernia or diaphragmatic rupture in trauma. Now, if there was signs of diaphragmatic injury, then you would typically see the gas within, and that would have all of the bowel contents within the chest, so it would look very different. Compare this with the right image. The trachea is moved towards the area where the whiteout is, and that's typically things like pneumonectomies. So there are some very odd looking gas bubbles within this area. It's very normal to actually get some air within a pneumonectomy. So I think this is probably most likely some form of pneumonectomy. Total lung collapse. So if there's an obstructing tumor, particularly around the left main bronchus, or whether there's some plug within there, some mucus plug, or another endobronchial type tumor. The other things that you can sometimes see are people with pulmonary agenesis or hyperplasia. They can look very similar, but you tend to see them in younger patients. So this case on the left is actually someone with a massive Ewing sarcoma. And this is the tumor clearly causing huge mass effect, pushing down the diaphragm here. The rib spaces, I'm not sure if you can make this out, are actually increased compared to the other side. And obviously it's pushing on the cardia, which is pushed over towards the right, and all the vessels are also pushed over towards the right. And in this case, pneumonectomy, so there's nothing on the left side. The right lung has expanded, it's crossing over the midline, and everything's, the cardiac is pushed over towards the left side. So next case. So yeah, so there's a comment, yes, you're absolutely right. So a massive pleural effusion can push the trachea towards the right side. That can cause mass effect, yes. So again, the quality of the images is poor, but the finding is there. So this case, immediately the hilar look abnormal. So the hilar are much bigger than you would expect normally. So typically you would just see the pulmonary artery going down there and a pulmonary upper lobe artery coming up there. Similarly, the same on the left side, but these are way too bulky. There's too much hilum. And like I said to you before, it's one of those review areas. So this is lymphadenopathy. So this is what it looks like on CT. Obviously, there's a wide range of causes of lymphadenopathy, which would probably be indicating more towards what's seen within the history. But it's to highlight the fact that review areas commonly misplaced, particularly amongst radiologists, is hilar lymphadenopathy. So I'm not sure this is going to project too well. So I'll talk through this. The first thing is density. So there's a definitive density difference between this right upper zone to this left upper zone. So clearly that's drawing your eye towards the right upper zone. Now, it's not projecting too well, but there is a line going along here. I'll zoom in a bit for you. So you can see there's a line along here. On my screen, they are a lot better, the image quality. But anyway, this is a pneumothorax. The key with pneumothorax is volume of the lung and vessels. So we can see here clearly there are vessels which stop before this line. There are absolutely no vessels in this area at all. So this is a pneumothorax. This coming along here, if you saw this, that's just a collapsed segment of lung relative to the pressure effect of the pneumothorax. So mimics, compared to the last radiograph, there is a symmetrical reduced density within both mid and upper zones. So whenever it's symmetrical, it's highly unlikely for someone to have bilateral pneumothoraces at the same time, unless there's trauma. So in this context, this is severe upper lobe emphysematous change. So you can see the normal pulmonary vasculature within the lower zones, and typically pulmonary emphysema affects the upper zones and mid zones more than the lower zones. And you can see here the vessels go all the way up towards the edges. A bit hard to see, but they do. So this is a mimic of a pneumothorax, and that's just simply emphysema. This case, I'll zoom in. You can see that there's a line coming all the way around here, commonly called pneumothorax, but in this case, the line extends all the way across the mediastinum, and this is actually a skin fold. So this is how the patient's lying on the detector plate when they took the X-ray, and it commonly is called a pneumothorax. The reason that I know this is a skin fold is that there is an increased density adjacent to the line all the way around, and the fact that it extends across the mediastinum gives the hint away that it's not a pneumothorax. So this is the next case. So hopefully everyone should get this one. This is pneumoperitoneum. So there's a gas bubble underneath the right diaphragm, and there is another gas bubble underneath the left hemidiaphragm. So whenever you've got bilateral gas, it's more than likely pneumoperitoneum. So there are some mimics, and it's something that we get phoned about quite a lot in someone with abdominal pain who has query gas underneath both hemidiaphragms. So in this case, clearly there is gas here and there is gas on the left side. The key for this is the fact that you've got some very odd folds in the gas on the right side. So these are horse straw folds within the bowel. So this is not pneumoperitoneum, this is gas within bowel. Similarly, on the left side, you have no horse straw folds and a very rounded bubble with a slightly fluffy lower edge. So this is gas within the stomach. Typically, pneumoperitoneum outlines either part or all of the diaphragm from top to bottom. So as the gas gets bigger, it outlines more and more of the diaphragm symmetrically on both sides. And it's very odd to have an asymmetric amount of gas on one side than the other, unless the patient is slightly malpositioned on the X-ray. So the CT image on the right side essentially just shows you what this is. So it's where the colon, specifically the hepatic flexure, is between the diaphragm and the liver. So this is just simply gas within the colon. So next radiograph. So this is a slightly tricky case. On the front of it, this is a shoulder radiograph. On the front of it, the lung looks okay. The bones all look okay. The humerus is in the right place. But this is simply a review area. So always look at the opposite lung. So that's a lung cancer. Patient was sent home. Fortunately, it got picked up. So just to show you there, that's the lung cancer. Easy to miss. So this is the next case. So this is two selected images of a CT scan. It's with contrast, so we can see that the pulmonary arterial tree is very bright compared to the aorta. So in unenhanced CT, the vessels typically look a similar density to soft tissue like muscle. This is obviously very bright. the key for looking at these and the images that they select is just looking for any area that's dark within the vessels. So there's no dark bits there. There's no dark bits in the main pulmonary trunk or in the aorta. But in these pulmonary vessels here and here, there are filling defects. This is what PEs look like on a CTPA. Typically in acute PEs, the thrombus will sit at junctions between vessels. So as the vessel bifurcates, that's typically where you get the thrombus sitting, as it just gets stuck in those areas. So in acute cases, this is what we see. In more chronic cases, the embolus tends to stick towards the outer edge of the vessel. And sometimes you can get webbing, which are just simply lines of old fibrotic clot sitting within the vessel. So that's PE. In PE, typically the chest x-rays are normal. So there are very rare times, just out of interest, very rare occasions that you can see changes of PEs on a chest x-ray. So here, there's an area in the right mid-zone where the pulmonary vasculature are hypoperfused. So the lung looks hyperlucent compared to the left side, and the right pulmonary artery is enlarged. So this is something called Westermarck sign, and the right pulmonary artery enlargement. So that's the CT scan, a large PE sitting within the right main bronchus, sorry, right main pulmonary artery. So this is the next case. So compare this CT scan to the last CT scan that we looked at. Clearly there's a different density within a different attenuation within the vessels. So this is an unenhanced CT scan, and then this is an enhanced CT scan on the right. So the aorta essentially is usually round. So the aorta at this point is not round, it's oval shaped. And on the unenhanced CT, there is an area that's of high attenuation. So high attenuation on an unenhanced CT is typically blood. So this is blood around the ascending aorta. So in this case, this could be basically one of three things. This could be hemorrhage from a ruptured aortic injury. This could be intramural hematoma, or this could be dissection. Hemorrhage typically will extend outside of the aorta. So you'd see it all in and around the chest. You'd see blood everywhere. So this is not hemorrhage. Intramural hematoma and dissection are part of the same spectrum of entity. So in this case, this is an aortic dissection, but this is the partly reformatted image. So essentially the aortic root is dilated. You have these funny, weird lines within the aorta. So this is a dissection flap within the aorta. So classification of aortic dissection is type A, from proximal to the left subclavian artery here. So this is a type A dissection. Type B dissection is distal to the left subclavian artery, so it will extend beyond. They're managed very differently. Type A aortic dissection is managed by the vascular surgeons, the cardiothoracic surgeons. The type B aortic dissection is managed by interventional radiology and vascular surgery. So there's a question about hyperlucent area also be a false aneurysm. So this is not an appearance of a false aneurysm. So the main reason why it's not a false aneurysm is the shape isn't correct. So typically the shape of a false aneurysm does not follow the shape of the vessel. Also, a false aneurysm would have enhancement within it, and there is no enhancement in the center of this area at all. So that's not a false aneurysm, but good thought. So next case. So whilst you're looking at this case, I think in terms of abdominal x-rays, they are over requested. abdominal x-rays have a very high false negative rate. So for me, there's only a few typical reasons why I would want to report an abdominal x-ray, and therefore follow-up of EVAR films, renal stone follow-up, or in cases of toxic megacolon. Otherwise, I would do a CT abdomen. You get a lot more information, and obviously the false negative rate of a abdominal x-ray is much, much higher than a CT. So this abdominal radiograph shows an obvious abnormality where there is a large area of gas-filled bowel in the center of the image, and there are also some dilated loops around the edge of the film, and there is absolutely no gas within the rectum. So this is a sigmoid volvulus. So the key parts of the sigmoid volvulus are that the gas-filled loops are in the center of the radiograph, and it looks like a coffee bean. So that's kind of all the way around the edge. And then this is the center here. So that's the two parts of the sigmoid folded against itself, and it's twisted around, typically the mesentery, and that's the sigmoid volvulus. So comparative to this, I'll just go through this one. This is the cecal volvulus. It's kind of more towards the right side where the cecum is. The key is that you see haustral folds. So if they ever see haustral folds within a big area of dilated gas-filled loop of bowel, then that's a cecal volvulus. So another abdominal radiograph. So in this case, in the left upper zone, there's an area of dilated bowel. It looks quite abnormal compared to the rest of the bowel. And there are some very thickened areas along the edge. This is a sign that's called thumb printing. So this is the impression of the thickened wall of the bowel seen on X-ray. So this is a segment of colitis. Now, colitis from a plain film is extremely difficult to differentiate between the causes, inflammatory, infective, or ischemic. So this on its own would warrant a CT without any clinical information. So this case is essentially similar to the last one, but far more extensive. The whole of the transverse colon is dilated, very dilated. And again, you're seeing this kind of thumb printing edge to the bowel. This segment coming down here, again, looks very abnormal. And there's a sign that's called featureless bowel. So this looks very featureless. And this is, again, a more extensive case of colitis. Now, the CT on the left shows you, again, this very dilated transverse colon. So this is toxic megacolon. So perforation-wise, that's typically the reason why you would look on an abdominal X-ray with toxic megacolon. For me, the key areas of looking for perforation are the edges of the film, in and around here, in and around here. And then looking close to the actual transverse colon to see if you can see the outer wall of the colon, and that's called Wrigler's sign. So if you see two walls of the colon, that's typically a sign of perforation. So this is another case. So this is bowel obstruction. Clearly, there's a lot of dilated bowel loops all the way through the bowel. This does actually have signs of ischemia. There's numerous areas of gas within the wall. So this is bowel ischemia. And this is what it looks like on CT. So again, pneumatosis within the bowel wall. And that's what you're seeing on the X-ray. I'm just slightly conscious of time. I've probably got a few more cases to get through. So a CT. So clearly in the liver, there's multiple liver lesions of low attenuation. So these are liver metastases. Typically, liver metastases that are of low attenuation are colorectal, lung, and breast. If they were hypervascular, so they appeared bright on CT, it'd be things like RCC, thyroid, melanoma, and neuroendocrine tumors. So this is another example, another case. So this case, there's a hematoma around the left kidney. So the hematoma is this large mass around the left kidney. It looks very similar density to the musculature. So essentially, this patient had a partial nephrectomy for a kidney tumor and then bled post-operatively. So actually the blood is extending all the way down here and across to the side. And there is some blood within the peritoneum along this edge. This is a perinephric hematoma. So I've just got a few more cases that we'll whip through. So hopefully everyone can see this abnormality and should be able to get this one right. So in the right cerebral hemisphere, there's increased attenuation area with some peripheral areas of edema. There's no midline shift. So this is a hemorrhagic stroke. Sometimes hemorrhagic strokes can be quite hard to differentiate between tumor and essentially the key differences are generally acute hemorrhage is much brighter, it's a much higher attenuation than a tumor. So this is a tumor here. The actual attenuation of a tumor typically is that of the brain parenchyma, specifically the gray matter around the edge. Also, tumors tend to have a much larger area of edema around them. And that's really how you tell the difference. Also, if something looks suspicious like a tumor, you would give contrast to look for tumor enhancement. So this is another CT head. So there's a very large area of gray-white matter differentiation loss in the right frontal, temporal, and parietal lobes compared to the left side. There's also a degree of midline shift. So we can see that the falx is pushed over towards the left side, and there is effacement of the right lateral ventricle. So this is a large cerebral infarct. This is in the MCA territory, so typically posterior frontal, temporal and parietal, and then the anterior parts of the frontal lobes are the anterior circulation, the occipital lobe, and the cerebellum are posterior circulation. So this is a slightly more subtle case. The key here is that there is area of increased attenuation within the left MCA. So this is acute thrombus within the left MCA, and there are some subtle changes within the insular rhythm. This is a large area of established infarct. So normal on the right, you can see normal parenchyma. Over time, you get encephalomalacia of an area segment where they've had an infarct. So this is a previous left-sided MCA infarct with an established area of encephalomalacia. It's typically dark. How you tell this difference from CSF, so sometimes you can get tumors that are cystic. It's very well demarcated foremost. It's in an area of arterial perfusion, and there are some subtle areas of residual brain parenchyma within. So that's the typical appearance of an established infarct. So another CT scan. So there's blood within the basal cisterns along the falx, and there is also scattered areas of blood within the sulci of both cerebral hemispheres. So this is subarachnoid hemorrhage, typically caused by some aneurysmal rupture or trauma. So in this case, there are features of early hydrocephalus. The ventricles are slightly enlarged. Typically, we would look for the temporal horns of the ventricle enlargement. So this is another example of hydrocephalus, a much more profound enlargement of the ventricles. You can see they're a lot larger than the CT scans that we've seen previously. And then this is another example of hydrocephalus, but this is caused by a tumor. So in the thalamus here, you've got an area of increased attenuation with some surrounding edema. And this is a contrast enhanced T1 weighted image. And this area of bright is essentially the enhancement of the tumor. And this was a thalamic glioma. And then this is the last case. So this is quite a nice case because it shows you two forms of hemorrhage, extra-axial hemorrhage. So on the right side, there's an area of increased attenuation along the right cerebral hemisphere. So that's a subdural, conforms to the shape of the cerebral hemisphere. On the left side, there is an area of hemorrhage, increased attenuation, which doesn't conform to the shape of the cerebral hemisphere. So that's an extradural hematoma. Now, inside this, there's actually a line here. So this is just fresh blood that's dependent within the hematoma on the right side. So that's just a fresh line of blood that's formulated. So the key with this as well, obviously, is they've got a large area of midline shift. So it needs urgent referral to the neurosurgical team. So to summarize, essentially, radiology tends to make a meal out of reports and recommend clinical correlation for all sorts of things. But in your case, for the exams, hopefully the cases will be more barn door. There'll be more common cases, and you won't need to do any image alterations to try and get the image correct. Hopefully, it will be much more straightforward. So, thank you.
And thank you very much. That was great. And just to reassure all of you doing the exam, the images will have been looked at on the same system that you'll be using by one of the question group to make certain the images are viewable and do show what we think they're going to show. So don't worry if they look a bit dark or dim on your PCs. Every image will have been checked by the exam board on the same kit you'll have for the exam. So don't forget, there is no revision course next week. We have got our SAM conference for all those who are logging in or joining us in London. It'll be good revision as well. We'll be back in 2 weeks' time when we've got Phil Dyer talking about diabetes endocrinology and gastroenterology. And then we've got the infectious diseases session as well from Dr. Craig Davis. Historically, infectious diseases has been probably the worst done by the exams for most people here. So that'll be a really good one to listen into. So we've got two last Menti codes. These will come up as word clouds. What did you like about this evening's session? And can we see the results of that anywhere? These are all nice and positive. And we'll move on to the next question. You have the next question, please, Jim. And what could have gone better for you this evening? Oh, that's a good first start. Ophthalmology probably won't be in the exam. You won't have any retinas to look at, as far as I know. Okay, thank you very much. And so thank again all our speakers, all of you for joining in, and we'll see you again in 2 weeks' time. Thank you, everyone.